Welcome to this edition of What's Up, Doc. Today we have a very special guest. We have the Chief Medical Officer for American Endovascular out of New Jersey and New York, an incredible group of what we call CLI fighters or CLI operators, critical limb ischemia operators. These are the doctors that work on the most complex blockages in patients with what's called peripheral artery disease. CLI or critical limb ischemia is the advanced stage of PAD with blockages in the arteries in the legs. A lot of these patients who end up in the advanced stage have blockages below the knee and into the small arteries in the feet. And their doctors really specialize in keeping people on their feet through advanced tools and techniques. And Dr. Elsie Ko is the Chief Medical Officer of American Endovascular, and she is here today to talk about pain relief from PAD. So many of these patients end up getting diagnosed and treated way too late when it comes to PAD. They advance to critical limb ischemia, and even when they do have blood flow restored, some of that pain continues. And that is a major problem. Medication cannot cut it. A general TENS unit cannot cut it. So today we're talking about going to the next stage if you have the discussion with your doctor about potential neurostimulators. Thank you so much, Dr. Ko, for joining us. We really appreciate you. Before we get into neurostimulators and pain relief for PAD, why don't you give us a little background about yourself?
Yeah, first of all, thank you so much for having us on here and for what you do, Kim. I really appreciate it. You're probably helping so many patients out there. My name is Dr. Elsie Ko. I'm an interventional radiologist, basically doing vascular care through a minimally invasive means here in the New York City area. And I've been in practice for over 20 years doing procedures like this. And the biggest reward is seeing patients getting better, whether their wound is healing or their pain is going away. We do whatever we can. We assess patients from the beginning to the end, whether they're referred to us or find us through social media, and figure out what is it that's causing them the problem. What's the circulation? Is it from the veins? Is it from the arteries? Is it from both? And after we've done everything that we can, I mean, if they're still experiencing pain, it's just that nerve damage is so permanent, it's not reversible, that we have to find something else. So we're the type of people who are trying whatever we can, whatever tools we have, whatever modern medicine can serve us to help patients live better lives.
Fantastic. And you have a special guest that's also with us that you brought along that's going to get into some of the technical details. Would you mind introducing Allie?
Yeah, Allie, maybe you can introduce yourself, but she's been a big advocate for patients working alongside us from Nevro and helping patients adjust when they get a spinal cord stimulator. We'll get into that, but Allie, maybe you can introduce yourself. Thank you.
Yeah, so my name's Allie. I'm the rep from Nevro. We work with high frequency spinal cord stimulators. So these are for patients with painful diabetic neuropathy, which I know goes hand in hand with a lot of patients that have also been diagnosed with PAD. So like I said, I work very closely with Dr. Ko and her team once a patient decides to move forward with this treatment.
Fantastic. How long has this treatment been around? I've heard about neurostimulators for a long time, and I'm curious how we've gotten to kind of the early days of experimentation to now they're suddenly mainstream.
Yeah, so spinal cord stimulators have been around since probably the 60s or 70s. Nevro's technology, which is high frequency spinal cord stimulation, has been used. It's been FDA approved since 2015. So we've helped over 100,000 patients in the US since 2015 with chronic pain relating to back and leg pain and painful diabetic neuropathy.
Yeah, I was going to say that I heard a lot about neurostimulators in the early days, basically for back, not necessarily for legs. At what point did the indication transition into legs, or did they just figure that a lot of the leg pain ultimately in the beginning was really stemming from the back, and then they're like, well, wait a minute, we can help with general leg pain beyond just what is stemming from the lower back or the spine.
Yeah. So like you said, it's been a long time since they've been used for back and leg pain. Diabetic neuropathy specifically, we've had the indication for since 2022. So we've been able to, like I said, help a lot of patients since then. But it was helping with diabetic neuropathy and neuropathy patients that maybe had back and leg pain that we put the device in originally for. We found that it helped with other types of pain as well, which is why we did the studies and now got the indication for diabetic neuropathy as well.
And I'm curious, Dr. Ko, you are the chief medical officer of American Endovascular, as I mentioned earlier, and you treat the most complex patients who have these blocked arteries in their legs, and along with that, the diabetic neuropathy as well, and just general neuropathy from these blocked arteries. At what point was there this aha moment to say, "Hey, wait a minute, you know what? We need to bring this into our practice and do this as well to complement our other revascularization procedures."
Yeah, it's interesting. I've been speaking to other specialists like myself, and there's some studies going on right now where we've seen reversible neuropathy, and it was incredible. But then, and it's, patients who are saying, "Oh my God, I can feel now the carpet under my feet." I couldn't feel that before. I could feel the sheets on my feet where I couldn't before. And then you have patients who just never get better. They get, maybe their wound heals, but they can't feel their feet. So you just so it was a matter of time before we research about treat other treatments for neuropathy, and having this liaison with companies who specifically do this, and them coming to us and saying, "Hey, do you think you can refer patients out for this?" I'm like, "What do you mean refer them out? We can do them ourselves." So we just like to have comprehensive care for our patients, and whatever we can do to have it all in house so that they don't have to, like, I mean, it's nice to have other specialties. Believe me, we like to collaborate with other doctors, but if it's something that's easy to do and safe to do in where we're doing already, and we know the patients intimately about what's going on, it makes sense for us to do this also.
So if you're doing these procedures, if you're putting in these neurostimulators in an office-based facility, it must be pretty simple, pretty quick in and out procedure under, I assume it's under twilight, not full sedation.
That's right. So most patients, as long as they can lay on their stomach, because some patients can't, they can lay on their stomach, and the sedation is not an issue for them. We can do this procedure because we do give them twilight, like you said. We give them fentanyl, which is anti-pain, and Versed, anti-anxiety medicine for this procedure. And along with local anesthesia, all we're doing is we're putting tiny little, they look like fishing wires for the tiny fish, not the big fish. And we're basically putting it into the epidural space. So if you've ever had injections in the epidural space or back injections for pain, you know what that means. It's going back there, and then we're threading these tiny little wires to go into the back, not into the spinal cord, but behind it, to basically stimulate the specific area in your spine to block that pain from going to your brain. The pain message from these mangled nerves that are no longer functioning and serving you well and creating significant pain, and we're just blocking that signal so it's not translated and you don't feel it.
Is it painful to, because I would imagine that in order to figure out which nerves they are and that you had the right nerves, you got to hit those nerves.
So the pain, when you're threading those specific wires up, most patients do not have pain. The only time that you might feel a little ooh, like or like a little wiggle of pain is if that wire's going around to the front. So we're very careful in the X-ray, because the X-ray moves side to side, to wiggle that wire right in the back of the canal in the epidural space. That's what's important. The local anesthesia has a little sting to it, but we give you the twilight before that happens, and really it's pretty simple procedure. That's the trial. Once you pass the trial, and the last patient I had said, "I have 100% improvement in my left leg, 50% improvement in my right leg, and 50% improvement in my low back. If your results are greater than 50%, you now can go to the next level, which is the permanent one." And that happens, after we get the approval. It could be a couple weeks later. And what we do is we're putting the same wires in, because we take them out after the trial just to see if it works. Okay. So it's pretty simple. The trial is very simple. The permanent's a little bit longer. It's a little bit longer, a little bit more pain. And what that means is we're embedding a small battery into under the skin on your back and your flank so that there's no risk. There's very little risk of infection when it's embedded. It's like putting a pacemaker. You know, some patients, you ever see patients have a pacemaker up here and you can see a tiny battery pack there. The same thing will be for these patients. So we put a battery pack that's rechargeable from the outside, which is amazing through Bluetooth, and it can recharge. You don't have to take it out. It's good for about 10 to 15 years, and it will stimulate that area to stop the pain. Allie, you can add on to that if you want. Oh, you got better lighting there. Nice.
Yes, I moved for better lighting. Yeah, so like Dr. Ko said, it's a two-step process so that you actually get to test out the device before you even move forward to that permanent side that she's talking about. That's more of like a pacemaker, but on the back. So first is the trial, where all we do is we put those wires in. It's very minimally invasive. It's more like having an injection than an actual procedure or surgery. And that battery pack actually gets taped to the back, where you get to wear it around and test it out for about a week before you decide if you want to move forward to the device that's a little bit more permanent. And as Dr. Ko said, it stays in for 10 to 12 years, and you charge it right through the skin. It's almost like a wireless cell phone charging pad.
And are there
And
any
the other benefit,
complications? Oh, and
I'm sorry,
here's
the other
Frank. Hi,
benefit is,
Frank.
hello, the unit is programmable. So, the vendors can adjust the strength of the signal that's being sent out.
Oh, that's interesting. Yeah, talk a little bit more about that. So, what is the process once they have one of these permanently embedded into their body? What is the
Mhm.
process by which it can be adjusted over time to ensure they're getting the maximum relief or the
Yeah, so
perfect amount of relief?
Yeah, so there's a lot of different settings that we test, and the device actually gets personalized to each patient. So if you decide to move forward to the permanent device, what we do is we download an app on the phone and you answer 4 questions daily. It's going to ask you your percentage of pain relief, your pain scale on a scale of 1 to 10, if you've had any change in activity, and any change in medication. So they're very simple, very straightforward questions that it asks you. Based on your answers to those questions, it will actually change you to the next best program for you. And the next best program for you may be different than it is for another patient. And if you are getting some relief on one program, it will actually take that, and like I said, it'll incorporate how you're feeling, how you did on that previous setting, to move you onto a personalized track of programs.
So, is this all done remotely, or is this all done by an algorithm, or are there humans
Yeah.
behind this
So
entire process to monitor these patients and make sure they're on the right program along the way?
Yeah, so while the app is an algorithm, and it's a personalized algorithm, there is a coach that's assigned to each patient that you can pick up the phone and you can call them. For example, I'm even the rep here for Dr. Ko in New York City and some other doctors in New Jersey. But all of my patients have access to call me during the day, during normal business hours. If they have questions, if they feel like they need to meet their rep in person, we can meet you in the office, while also helping you reprogram the device over the phone. If you'd rather do it from home, you can do it from home.
And what are some of the complications that you've experienced with this device that patients should be aware of? Dr. Ko?
Yeah, so there's the same complications you would have mainly with most procedures where you have to pierce the skin for whatever reason. So you always have to watch out for infection, for bleeding, to make sure that the patient has not taken any kind of aspirin, Advil, Motrin, any of the NSAIDs, what we call non-steroidal anti-inflammatories, at least 1 week before. If you have any bleeding problems, we need to know about it, because God forbid, we don't want bleeding and from your back, so especially with the permanent, not so much with just doing the trial. So we're very careful about that. We will give you IV antibiotics prior to the procedure and a 5-day course of oral antibiotics to help reduce risk of an infection. If God forbid there was an infection, which is pretty rare, then we would just take it out. And if you need IV antibiotics, you need IV antibiotics. And that's usually the main kinds of problems that can happen.
I know it's rare, but there are patients that we've dealt with that have had sensitivities to certain metals and materials and things like that. Have you encountered any situations of that kind where you have to ask the patient, hey, are you allergic to any of these materials before you go ahead to implant this device?
I have not. Allie, do you have any experience with that?
I haven't. Usually, when a patient does have a sensitivity to a metal, they're kind of forthcoming with that. They let us know. We do have a list of metals and materials that the device is made of. So if the patient does have a sensitivity, we can definitely get them that list, so they can ensure that whatever they may be sensitive to is not in there. If it is,
And
and it's a part of an external part of the battery, it may not just be the right course of treatment for that patient.
and we have a question from our live studio audience. Heinz, go ahead and unmute and ask your question.
Hello. My question, plain and simple, does it cause any issues if you have stents?
No, it does not. That's a good question. Thank you for asking that. Are you talking about stents in the heart or stents in the legs?
Stents in the legs.
Yeah, no, in fact, we've placed them in patients who have stents in the legs, and for the very fact that, the PAD symptoms did not improve, and we have to put that in. So it is not it's not anywhere near, and it's not affecting your legs.
Any interference with pacemakers or defibrillators?
So it's very localized stimulation to the epidural space.
Mhm.
Uh, Allie can talk to some of the specifics or technical aspects if she's still on. Otherwise, it's just not, it is basically two tiny wires with really tiny beads. And you can see them overlapping, and it's basically causing electrical stimulation to the epidural space. So it's not really traveling anywhere in the body. It's not magnetic, or, if you think about MRIs, CAT scans, or those kind of things. And because sometimes people get concerned about that.
Yeah, typically doesn't interfere. I've never had a case where it has. From time to time, depending on which device they may have, we always have the patients run it by their rep for their pacemaker or their defibrillator. Sometimes the reps like to be there to monitor that device during the procedure, but like I said, we've never had an issue.
What about going through the airport? Any delays at TSA because they have to get a full pat down?
So you will have a card that gets mailed to you. It's like a hard copy credit card you can keep in your wallet. It says that you have an implantable device. Actually, if anyone's traveled recently, they actually have added spinal cord stimulators to their little posters as you're walking through TSA that just says, please notify us. They'll have you walk through like the old school metal detector, not the one where you put your hands up and it spins around you. They'll have you walk down that one, but it's something that is their TSA is very familiar with, so shouldn't be too much of a holdup.
That's good because that's always really tough. I always call my dad the titanium devil because he literally he is full metal all the way through his body, and so he always has to get the full pat down. He's like, I'm ready for it. I'm ready for it. Been there, done that. And so we always get that question from a lot of patients as well because they just, you need to know that. And you need to know ahead of time and be prepared and be forthcoming when it comes to going through if you don't want any critical delays with
Mhm.
TSA and travel. What about indications for this device? I know we talked a little bit about it, but more specifically, what are the patients that you say, okay, I know you need one of these? How does a patient know when it's time to put in something like this? I know it needs to be a discussion they have with their own medical professionals, their own medical team, but can you give us any indication?
Yeah, so in general, we want patients to try some conservative therapy first. Obviously, if they have peripheral arterial disease, we want to treat that first. We want to make sure they've tried gabapentin, or they've tried medications for neuropathy, have seen somebody who's been diagnosed with neuropathy, meaning most patients have numbness, they might have tingling, burning sensation, or sometimes people say their feet are on fire. They have a history of diabetes. There are patients who have ischemic neuropathy who can have this. As Ali said, sometimes they have radiculopathy, which means you have pain that's radiating from your lower back down your legs. So, we'd like to see patients who've tried some kind of physical therapy to see if that would help. And if you failed all of those things, your diabetes is under control, your A1C is under control, under 10, then you really do qualify, and most insurances will pay for this procedure. We'd have to document all that. It's very important. And after we've tried that, we will submit it and have you go for a trial.
I know this goes off into the weeds just a little bit, but you bring up such an important point is with getting your diabetes, your A1C under control. Can you talk about how the high A1C and having so much sugar in the blood actually triggers pain, actually causes pain?
I don't know if it actually causes pain, and maybe, Kim, you have some kind of article in your mind because you've already brought this up. But we do know that sugar is almost like poison to your body, and the sugar can cause damage to all the tissues, whether it's in your brain, your blood vessels, your organs. We see it time and time again, and that's why it causes slow damage to your nerves. And the sugar also puts you at high risk for an infection. Okay, so if your sugar is out off the charts and we have to do surgery on you, that puts you, because bacteria love sugar.
Yes.
Bacteria wants to eat sugar. So if your blood is sweet, it wants to go in. So that just puts more risk and more risk of complication that we don't need to have.
Such great points. And then on top of that, it leads to damage to your artery walls, and that causes the plaque buildup, and more blockages is more pain. And then beyond that, it makes your blood thick and sticky, and the blood can't get through those small capillaries to even get to those critical nerves. And so they're firing, they're saying, "Hey, I need nutrients, I need oxygen, help me." And so that's
Inflammation. It's
really
inflammation that causes all.
inflammation.
Mhm.
Yep. So I just want to drive that home because we do have a lot of people in our network and they have high A1Cs. And no matter how much we just keep harping on the fact you need to get that down, you need to get that down, the picture's just not painted for them. And they'll complain about pain and they'll complain about the burning, the tingling, and things like that. And it can be as simple as just monitoring that diet, getting that A1C down. You can actually get some great relief just from that alone. And we've seen it. We work with Dr. Michael Danziger, who's a diabetes reversal expert out of New Hampshire and Massachusetts. And he meets with our patients once a week on Mondays and, just as a group, but then he worked with several patients one-on-one. And he has managed to literally reverse neuropathy that the patients were experiencing by getting their A1C from 13, 11 and 12 and 13 all the way down to sixes and sevens. So it's pretty ridiculous and really powerful. But if that still doesn't work and everything has already, just the damage has set in, the nerves are on fire and you need to take the next step. It's nice to know that neurostimulators are here. And what type of doctors, aside, actually, I was going to say aside from interventional radiologists, are interventional radiologists the only ones that are implanting these neurostimulators, or are we seeing that with orthopedic surgeons as well?
Right. So there are other specialists, anyone who does spine work. IR doctors do vertebroplasties, they do other kinds of spinal epidural injections, but so do pain doctors, so anesthesiologists or rehab doctors, sports medicine doctors, orthopedic surgeons. So it really just depends. It's not like everybody in those fields can do it. Not all IRs, not all orthopedists, not all anesthesiologists. Is this those specific doctors who have subspecialized and been able to do it can do it.
And again, Heinz from our live studio audience here, he has another great question. Heinz, go ahead and ask.
Yeah, hello again. With this neurostimulator device, can you still have PAD or CVI procedures?
Yes. In fact, we sometimes go back and forth, like even after I have patients who've had the neurostimulator and still need to have a follow-up exam with ultrasound. And if they still have issues with their circulation, they have claudication, they walk and they have cramps in their calves. then it's a superimposed issue with circulation. So yes, you can have the PAD procedures while having the neurostimulator in place. Good question.
And we have Kelly who's asking, what happens after the 15 years when time is up?
Yeah, so when it is time to replace the battery pack, what we do is we make a small incision where the battery pack is placed, and we take it out and plug a new one in. It's a very quick procedure, only takes about 10-15 minutes. But
And
the wires we place stay right in the same spot.
oh, fantastic. And so that's a pretty basic procedure. It's not going to be as extensive as before.
Correct.
Okay. And we're getting a couple other questions in here. So Laurel wants to know about how do you choose a doctor to determine which one is right for you that you're going to get. I mean, it's probably all about it has to be implanted well, right? So, how do you know that your doctor is going to be the right one to do this procedure for you?
That's kind of a very general question because how do you know if the right person is going to do your fibroid embolization or your deliver your baby or take your gallbladder out? So, a lot of times in the past, people used to really depend on referrals from your primary care doctor, referral from a specialist, a friend who referred because they had the procedure. But I think these days, what's good is that patients can search online and see what kind of reviews physicians have had and providers. It's more transparent than it was ever before. It might not be 100% accurate, but at least it gives you an idea if you have no idea of no way of getting a referral from somebody. To look on social media platforms, to look on reviews, and there's so many different kinds of reviews out there, health grade for physicians and providers, ZocDoc. So to look in your area, I don't know where you're from, but also there's certain societies, physician societies that will help you find the right doctor. And Kim, I mean, you're a great resource to a lot of patients out there when they look for a resource. Look, she's got the hotline right there, Leg Saver hotline. And I already know from personal experience seeing how she has helped patients in dire straits because they don't know where else to go. So please depend on her and lean on her. That's why she's here. She's doing a great service to patients.
Yeah, I will. I get on the phone with the doctors like you. I get on the phone with our friend Frank, the CEO of American Endovascular. I bug everybody, and if I don't know a doctor that does it, I will find a doctor who does it and does it well for you through our incredible network of CLI operators, the most advanced operators for treating the neuropathy, the blockages, everything going on with the legs. But Robbie wants to know about critical questions to ask a doctor prior to having this procedure to determine if it's something that's right for him,
To determine something right for them.
to determine if a neurostimulator if it's the right time for him. Are there critical questions he should ask?
Well, I think the doctor's going to ask you all the critical questions, but be ready with the answers. Be ready to tell them your history. Be ready to understand, okay, what medicines have I tried? Be ready to tell them what blood thinners that you're on. Be ready to tell them what kind of, because a lot of times what's frustrating for physicians is when patients don't know their history. And it's really hard. It's like a guessing game. And then we have to search. So if you are more organized about your health, and you have a record of all your medications that you're on, the allergies, how long you've had diabetes, if you have been seen a neurologist, what kind of symptoms you have, and you are ready to answer this. You might not necessarily have it at your fingertips, but if you keep an organized record of your history, we need to know if you've had back surgery. That's important because if you have scar tissue in your back, it might make it really hard for us to do the procedure. So, so it's not a matter of what critical things you need to ask. It's more like, how much can I be ready to tell the doctor that everything that that doctor needs to know? And the more organized you are about your health, what allergies you have, what surgeries you've had, the better we can help you.
So one of the big things that I just want to point out again is if you have had back surgery, that's a really important point that you need to make sure and be upfront with your doctor about. It doesn't mean that they can't have the neurostimulator implanted. They just need to be able to look at probably the MRIs, the X-rays, and everything to determine proper placement so that that doesn't interfere, the
Exactly.
scar tissue doesn't interfere.
Right. I had one patient whose daughter said, "Oh, she's never had any surgery done, just epidural injections." I'm like, "Okay." Later on, I find out she did have surgery. So it's like, wait, where are we? And then we had to get the records, and it turns out she had at L34, which is the lumbar spine, she had a hemilaminectomy, which means they removed a piece of her bone there.
Oh, wow. Oh my goodness.
Yeah.
It reminds me, I can't tell you how many procedures I've been in where the doctor says, gosh, this patient said they've never had any procedures before. This is my first procedure on them, and they're just laden with stents.
Exactly. I've seen that too. I've seen that too.
How did you not
Yeah.
know that you
Yeah.
how is that possible?
And sometimes it's the patient, sometimes it might be the provider, sometimes maybe they told them and they were sedated still, or maybe they didn't tell them, or maybe the patients forgot. There's so many reasons, but having that advocate with you also is very helpful. If you're an elderly patient, if you have family around you to help take notes after the procedure, that's really helpful.
Right. I mean, you make a good point as well that sometimes the physician doesn't tell the patient what they've done. And I've
Hopefully
had it
they have, and I would like to think that most physicians do. I
there
think.
is an exception to the rule. And for
Okay.
some reason, they always seem to come my way where patients have had dissections. We had a tennis player out of San Diego, and the doctor just told him one day, well, you need your leg amputated. And he's like, I don't understand. How is it that, I go in there for a procedure and I'm coming out and you're telling me I need an amputation? Like, this doesn't even make sense. I don't even have wounds that won't heal. Well, it turns out he had dissected the vessel and didn't know how to fix it. And of course, flow limiting dissection, at the popliteal, well, it's only a matter of time, right? So he goes to this other doctor, and the doctor said, well, I can fix that. And I can tell you why. But that's really sad that the doctor wanted to go straight to amputation. I don't know, hate to say it, but covering up the mistake. I'm not sure, but the patient had no idea. He was just like, nope, I can't open up your blockages. Didn't tell him that he caused the dissection, but that's neither here nor there. I always tell patients, you always need to get a copy of your case notes. They have to put everything in the case notes. And most doctors assume you don't really read them, even if they're there, or if they're there and you do read them, you won't understand them. But we tell the patients, get them, bring them to us. And we have a great team of doctors and clinicians, around the world that will take a look at it and help us to break it down for patients who tune in.
That's
So
it's great that you have that resource to be able to send patients to, somewhere else to get help when something like that happens. And hopefully it's pretty rare. And yeah, there are definitely some bad apples out there, but hopefully most doctors aren't like that. That's just so sad. I don't like hearing stuff
there,
like that from a physician standpoint.
I know they're few and far between, but the funny thing is, I think that every one of them ends up coming my way. So it's a little bit amplified, in my world. But no, it's definitely the exception, not to the rule. Um, but I want to drive home. So we always get calls from patients following procedures such as this, with questions. Well, um, is this a symptom? Should I go to the hospital? What are the signs and symptoms and such that people can expect following the implantation of a neurostimulator, not just the temporary one before the permanent placement, but once you permanently place one, you have the procedure. What can a patient expect in terms of the recovery process?
You're definitely going to have some soreness in your back because there's going to be two incisions. One incision about this big is in your back to basically place the wires, okay? And then another incision about the same to put in the battery pack. So you are going to have soreness in your back. So, and the neurostimulator that you've had implanted before for the trial will not be turned up to the same level until 1 week later. We want to make sure everything's healed. So you're gonna be sore from there. We are gonna prescribe you. Depends on the patient. Some people don't need it. We can prescribe a small dose of narcotics just for the first day or two, and we can prescribe you some. We can prescribe you some higher dose pain medicines that are not narcotics, non-narcotics, okay, for the pain. And you're going to be limiting your motion in terms of twisting, bending, lifting. You don't want any of that kind of to move anything around. And you're going to come back in 1 week. We're going to make sure everything looks great. Then we turn up the frequency, and that's where Allie comes in to save the day. And then you finally feel some relief because initially it's only going to be at 14%, which is very, very low. Some people might feel some relief from just a little bit of stimulation, but it's not like you've had with the trial because patients might say, the heck, I thought I was supposed to feel better. You're not going to take a bath, okay, and you're going to keep that area clean and dry. So sponge bath is what you're going to have to deal with for the first week. Once we see that the wound is nice and healed, then you can start taking a shower, and then we'll approve you for the bath if some patients like to take a bath.
I know my dad loves the hot tub, so
Yeah,
that's a
exactly.
big thing for him when he has any sort of procedure done. Okay, when can I go back into the hot tub? That's all I care about.
Exactly. Some patients, it helps them with their neuropathy, and the radiculopathy too, their back pain. So,
So we have Robert with Pad Life Outdoors. He's an incredible PAD warrior, and he does a lot of videos about the outdoors and hiking and biking and everything for people with PAD. And he's curious about lifestyle changes following the implantation of this device. Is there any limitation? I'm sure that these patients are not, going out and playing football or, you know, hitting home runs, on the diamond or anything like that, running marathons anyway. But I'm wondering. I mean, I'm sure they feel a lot better to the point where they may say, "Oh my goodness, maybe I now can get back to being a triathlete again." What would your guidelines be for these patients? Can they go from zero to hero? What are the limitations?
I think it really depends on the patient. I mean, the patients that I've been dealing with have been middle-aged to elderly, and everyone, some people are we see marathoners up to age, what, 99. I think the Guinness Book of World Records is a 99-year-old who ran the marathon. But I really think it's so individual to the patient. I've had patients say like, "Oh my God, I've finally been able to sleep through the night." I mean, sleeping through the night, and then they feel more energized and more active. But if it, some patients can finally walk down to the local store. So I think it just depends on the patient. If we feel like, we don't want anyone to change their lifestyle, but in general, most people are more energized to do the next level thing. And we're not going to we want patients to be able to live their lives. So that's the whole point of this. Being a triathlete and lifting 300 barbells. I don't know if that's something that we're going to ask them to do, but we certainly want them to be healthy with some limitations, because
Yeah.
you still don't want to we don't want wires to move. We do put some anchors in there to really hold those wires in place, and we do suture it down pretty deep, but you still want to, sometimes check on it if there's any change in the way they feel, from, Allie helping them out and then calling and say, I don't feel the same or relief anymore. We'll do an x-ray to make sure the leads haven't moved. That's like one of the other complications that can happen, that these wires can move with your movement, if you can imagine. So 300-pound barbells and doing P90X on Beachbody, I don't know if that's something that you should be doing, but you certainly want you to get to the next level in your life.
Yeah, my
Allie, do
dad.
you think of anyone add to that, Allie?
Yeah, I was going to say, as far as like restrictions and what the device is restricting you from doing, it's not much. After the surgery site, both surgery sites have completely healed. Usually that's around 6 to 8 weeks for that scar tissue to build up around the wires and really cement them into place. There's, as far as like your activity level, there's really no restrictions. We have had patients that have run marathons and done triathlons. So it's not the stimulator that will limit you from doing that. I mean, if there's other things going on, I wouldn't be able to go do a triathlon right now. But like I said, it's not the stimulator that's keeping patients from doing stuff like that.
Yeah, I can imagine doing the deadlifts and that type of activity could end up leading to those leads moving around where they
Mhm.
shouldn't be.
Yeah.
Um, but I know for my dad ended up with a cortisone shot recently, and the cortisone shot, he's bone on bone in his hips. We're waiting for hip replacement, and he got a cortisone shot, and he was so excited that he felt so good. He went out and he did a brisk 2 mile walk 2 days in a row, and had his trainer come over, and he was doing the squats and step ups and all that stuff, and then suddenly he woke up a few mornings later and he's like, I can't move. It doesn't work anymore. We need to go back. And the doctor was like, and what part of taking it easy did you not understand?
Oh, no.
The problem is when you feel better, you still need to keep in mind that you need to let your body heal. There's still some work that needs to be done, such as what Ali was saying. You need to allow some time for that scar tissue to build up to maintain those leads in place. So no zero to hero right out of the gate. It does take, you mentioned, 6 to 8 weeks for the full process of real healing and the process of just slowly, gradually improving or increasing the the electricity or the stimulation,
Stimulation,
correct?
yeah.
Okay.
I want to say that some patients also build scar tissue differently than other patients. So, you know, we put in catheters for many other reasons in patients, and it's amazing to me that some people might have this catheter that'll just fall right out, like for dialysis, for instance. And others, you can't get that damn cuff out to remove the catheter. So you're like, what the heck? So everyone's made so differently inside as they are on the outside, and the collagen makeup, that's so fundamental to underneath our skin, can also affect the medical outcomes for patients. So, and just like, aging, we say, like, why do African Americans look younger at age 60, and some women who are maybe white skinned and have very thin skin age quicker? It has to do with the collagen makeup. So the same thing with internally with wires and catheters, balloons, whatever. The collagen makeup makes such a big difference. So that's why I say it's very individual for patients and what things that can happen.
So make sure, for all of us who are watching, this is for educational, informational purposes only. Always check with your doctor before acting on any information provided here and get their explicit consent. Just because you hear the information does not mean it is right for your presentation of disease, but always get a second and even third opinion from different types of doctors who might offer these types of procedures to determine if it's right for you. And as we close here, we have 4 questions we ask every single doctor. They're a little bit of a surprise. If you can answer them,
Uh-oh.
great. Sometimes they're thinking questions, and they're sponsored by 2 different companies, Reflow Medical, which I know you know very well. They have that retractable stent that they're waiting for FDA clearance for, already got CE mark. And you have Biomedics, which has the PadNet testing device. So they air in our radio show. Our radio show airs on KDOW in the San Francisco Bay Area with 27,000 streams every single episode. So there are going to be a lot of people that listen and tune into your educational break. So I'll start with the first one, which is called The Pulse. And we just ask that you share a case in which you learned something from that others could learn from. It could have been, and we're talking physicians and clinicians, but also breaking it down because the patients are tuning in. But it's really geared towards physicians and clinicians. It could be a success, it could be a failure, but something you learned from and others could learn from as well. And I'm thinking it might be appropriate, but not limited to, talking about the implantation of the neurostimulators for people with PAD.
Yeah,
But
so I think what I learned was that patients, the ability to do these procedures, and if this is towards clinician, is can be your experience with doing this can be so drastic from being so easy and quick to being a little bit tougher and time consuming, but still doable, based on the collagen makeup of the skin. I was thinking about that because we're talking about collagen. And for instance, the last patient I did really took much longer because she's African American, and just digging in, and I don't want to gross anyone out, but to create the pocket for the battery was very difficult because the tissue is very fibrous. And without getting too into the weeds of how, because people get disgusted, it just took longer because it's very tough, very tough. These, they're tough. So just be mindful when you see somebody and you're timing your procedure to understand you might need a little bit more time for patients, and has nothing to do with race and discrimination, just has to do with the ease of doing the procedure.
that's good to know. I think that's really important for people to know, and that could be for any type of procedure. And I would imagine that weight is also a consideration.
Absolutely. Yep. The deeper the harder it could be. So the thinner the patient, you don't have to go as far down. So
And is that a consideration when you are considering to do a procedure on someone? Have you ever had to say to them, hey, I think I need you to lose about 25 pounds and then we'll do this because it's just going to be a lot tougher of a procedure and the recovery is going to be more extensive and it's probably questionable whether it'll have the most significant impact on you if you're at this weight.
yeah, I mean, if they can't breathe, because they have a lot of weight and they can't lay on their stomach, and they're over 400 pounds and or 500 pounds, depending on the weight limit of the table that we use, you could break the table. So those are major considerations. Um, but the most important is, can they breathe? Because we want them to breathe even with the sedation. And when they're prone, you can't like get to their airway to help them with oxygen if we had to put a tube down their throat or something because they stop breathing. So it is very important. Weight can be very important consideration for this kind of procedure.
And I would imagine then also along those lines, people who have COPD
Oh,
probably would.
yeah. It's a very good point. Yep. If they have COPD, they can't hold their oxygen. They're below 90% O2 saturation. When you put that on your finger, it might be risky. So we are very careful and we consider every detail, making sure our patients are safe.
Tell me about a case where you just couldn't stop shaking your head. How in the world did this patient get to me so late? And you still think about this case right now because you're just thinking to yourself, I just don't understand in today's day and age how a patient like this has gone through this journey and has gotten to me in a train wreck type of situation. Like, how is it that they missed this all along?
Well, you know what? I actually don't get that surprised anymore. Isn't that sad?
It's so sad, but it's true.
It's sad. Because I mean I'm in practice for over 20 years now. So yeah, it used to shock me in the past. But I think because I'm older than you think, and maybe my Zoom is filtering my wrinkles, but I think um nothing really surprises me. Yeah, there are some times when I'm like, what the heck? I don't get this. I think what surprised me the most is when I get a patient and it doesn't hurt. The findings that I see on X-ray and I'm injecting the dye in their arteries, and it does not coincide at all with the ultrasound that was given to me. So you'd be surprised as a patient, and like patients don't understand this, but I understand it because I've been in practice for so long, that you might be getting an ultrasound that says everything's normal, there's no blockages anywhere. Maybe the flow is a little bit slow, or maybe the phase is not as strong. But I go in there and the patient's living off a thread of a blood vessel. And that's when I'm like, what the heck? Like this is not what I expected. And of course, I still am not that surprised, but it still bothers me. It bothers me that this patient has had this for so long, and it's just the ultrasound is probably one of the reasons why, because the ultrasound reading can be so varied based on who's doing it. We train all of our techs where we have a quality control. We have to watch and make sure each and every new tech who comes on board knows what they're doing and reports correctly.
We've had about half a dozen patients that have come to us and said, I don't understand. My doctor says, and they come from a small community hospital. My doctor says my ABI test is normal, my ultrasound is normal, but I literally cannot walk. And they're telling me it has to be coming from my back, but the MRI comes out inconclusive, unremarkable. And I say,
Exactly.
okay, let
Exactly.
me let me get them to a different doctor with a different technologist to read it. And lo and behold, PAD.
Not surprised, yes.
And
It
so
frustrates me, but it doesn't surprise me. How's that?
I always tell patients you have to advocate for yourself. Don't just take it. Doctors do not diagnose just based on an image. They really take into consideration the symptoms. And so if your symptoms are
Exactly.
not matching that image, and it can
Exactly.
go both ways. You need to get a second and third opinion and just understand, as Dr. Ko said, that different people have different experience in reading these and can read them different. And people, we're human and people can make mistakes. So don't become the victim of the mistake, rise above and go ahead and fight for another opinion and another test if needed. If you're feeling those symptoms, don't sit and suffer.
That's right.
Oh, okay. So the next one, and I think I'd like you to bring in the neurostimulator into it and give a little bit of explanation because as we go into this one segment, it just needs a little bit more an explanation. And we call it "Go with the Flow," and it's inspiration for people to walk, and it's tips and tricks on walking as medicine for PAD. And so I think that's a great opportunity to bring in. We've talked about TENS devices to help, but if you've had the revascularization procedures and you've gotten more blood flow, but you still can't walk, and you're still getting that burning, tingling, and such, maybe to ask your doctor about a neurostimulator. So I think maybe that's the direction to go with that. So if you wanted to just take it where you want, it's a Go with the Flow series. There's no introduction, it just goes straight to you, talking about walking being the best medicine. And if you're struggling, what you can do and the questions to ask your doctor.
Yeah. So, we always try to think about what else can we do. If the patient's living off of one blood vessel, and normally you're born with three blood vessels going down below the knee to your foot, and if you're only living off of one blood vessel, and there's no way we can open up the other two because they've been so closed for so long from top to bottom. There's no landing zone. We're like plumbers of the human body. We can't do it. So then we think, okay, well, what else can we do? Anything to help improve the blood flow down. So neurostimulators, and I know Allie's not going to talk about this because this is off label. So Allie's from industry. So I do know that in Europe, okay, they use neurostimulators to help improve the blood flow to the foot. And they were showing that it causes vasodilatation of some of the blood vessels. So there's some early signs that this is another way in which neurostimulators may be helping patients with peripheral arterial disease. Again, this is not hardcore science. This is just like, hearsay what we're learning from Europe, because Europe tends to get the the products earlier. As Ali said, they've had it in Europe way before we have in the US because of the FDA. And so sometimes they do studies before we do, and we learn from them. So one of the things, and just, as a last thought, is that maybe it's not just helping your neuropathy, but it's also helping your circulation on a on the micro level.
Right. And we talk about the importance of walking as medicine to build the collateral network of vessels. But these neurostimulators, as just a side effect, we'll just say, um, can actually help stimulate those collateral vessels as well. That's a really good thing for those people who have just that one vessel runoff into the foot where the other two vessels they can't open up. And your body can survive on these collateral network of vessels. And that's a pretty remarkable feat. So I hope they are doing studies on that to be able to create some clinical evidence so that we can get it here in the US if it's appropriate and get insurance to cover that as well as an indication. And one final question. This is a fun one. We are asking physicians about a defining moment in their career, a catalyst for change in a direction, a trigger for how you became who you are today. It could be any moment in your career. We call it the 6 minutes that matter. It could have been a conversation you had with someone. It could have been a patient you saw that became a defining moment. Even a scene in a movie that you've watched. I've had someone talk about that. Another doctor talked about the birth of his first child, and his wife saying to him, "Hey, you got to show this kid it's fun to succeed, and you don't look like you're having any fun. What would it mean for you to have fun?" And he said, "I want to be an angiologist." And so took his career into a whole new direction. So keeping that in mind, do you have a defining moment that you'd like to share?
Your questions are amazing. I did not expect this at all.
The fun
Yes,
part of the
I
whole
do.
thing.
I actually did a TEDx talk on this. And as a young doctor in a surgical center, and Frank was there. So Frank, you can talk about it. Um, I was just not prepared for leadership. I was not prepared to be the medical director of a surgical center, 2.5 years outside of training. And I failed completely. I felt, how do I fail? How do I know I failed? I failed because I was told by one of the manager, not Frank at the time, but a different manager, years, a little bit, maybe 5 years into my practice, that I had made each and every person cry in the surgical center. And I thought she was joking. I was on a party bus going to a Christmas party. And I said, "Oh, very funny." And she looked at me and she was serious. And nobody else was looking at me. And I was on, I don't know, Frank, were you on that bus, Frank? I don't think he was on the bus, but that was
No comment.
that was a defining moment because I didn't realize, I knew I made like one person or maybe two people cry, but I didn't mean it. And I said, I apologized afterwards. But that was a defining moment because I was like, holy crap, this is not who I am. The nice Korean girl from West Virginia, my parents brought up and always did everything my parents wanted. I'm the nice girl. What happened to me? And then I realized that I needed some coaching. I needed some training. I started reading a ton of books, to and from back in the day when there were CDs. I listened to so many books on personal development, on leadership. Fast forward, I ended up getting an executive master's in healthcare leadership, and I became a leadership coach. I've had been coached, and then I now created my own coaching program for physicians, knowing that we study so much, we study so hard, we don't get time. We don't get time to think about how to interact with other people, and we might not be the best at our manners and the bedside with patients, and we don't treat our employees who are so vital to our success, and vital to our happiness around us, with the respect and the awareness that we need. And so I teach this because it's number one is learning self-awareness. Number two is learning how to have true self-confidence, not pseudo self-confidence and telling everybody what to do because I'm the boss. And then learning how the leadership skills that are so vital for healthcare. And I think, going forward, in my career, I'm going to continue that when I have time, Frank. I've developed an online program and I'm continuing to revise it. And I hope that I can help physicians do better and be leaders in healthcare so that we can have, I think the real change in healthcare needs to come from people who are from the ground up and are doing the healthcare. And without true leaders, we can't have proper change.
I love that. That was actually that was a beautiful way to end this conversation and just the beginning of future conversations with you as well. I think that that's incredible. To be a leader is to lead by example, and actions speak louder than words. And you definitely define a true leader. And I love that there are so many people that could have taken that moment and said, "Well, who cares?" And I've seen them continue on in that direction and not realizing that to be a leader is you really need to embrace people. You need to have that self-confidence, the self-awareness that there are ways that you can motivate them and inspire them because people inherently want to do good and you just have to bring it out in them and help inspire them. So you've inspired all of us. Thank you so much for joining us. Thank you, Allie. Thank you, Frank, as well for being here. We really appreciate it. And for those of you who want to learn more about neurostimulators, Allie, is there a website they can go to?
Yeah, yep. So the company is Nevro, Nevro. So they can just go right to the website, nevro.com. There's a patient side to the website. And even if they're looking for a physician or want to hear more about the device, they can put in their contact info right on the website and somebody from their local team can reach out to them.
Fantastic. Thank you so much, Allie. We really appreciate it. And for those that want to learn more about Dr. Elsie Coe and her team over at American Endovascular, I know that by heart, AmericanEndovascular.com. And where are your facilities? You have quite a few facilities. I'm always very familiar with your orange.
Yeah.
Your
So our New
Orange, New
York office
Jersey.
is, yeah, the West Orange. Then we have an office in Brooklyn, which is Dr. Coe's primary site. We're in Long Island City. We're in the Upper East Side on East 116th Street. That office is the ambulatory surgical center, which is where these procedures are done. And then we just acquired a practice in the Bronx. So.
Okay, fantastic. We really appreciate you. And Dr. Coe, thank you so much. We hope you come back again on a variety of different topics. You do a lot of different things there over at American Endovascular, and we're always welcoming you back to join us again.
Thanks for having us.
Yes.
This was very
Thank
enlightening.
you. And thank you, Kim, for everything you do. You